Oh, hello there. Welcome. We are going to be talking about microtia and anotia, which is a outer ear disorder. It's very fascinating. I think you'll enjoy it. I do want to let you know before I even get started, I have posted along with the video textbook notes, links, and lots of extra opportunities to practice. I also, at the end of the video, have a fun fact because we are all audiologists, so we should be ear nerds. So there's some fun facts also. Um, but let's go ahead and get started with microtia and anotia. So the pinna, it's also called the auricle. Our textbook notes that the pinna functions mainly as a sound collector for different frequencies. These ridges and depressions on the pinna cause it to function as a complex resonator, especially for high frequency sounds. So what would happen if we didn't have a pinna at all? Or what would happen if we had a small pinna? Or if we didn't have we didn't have an ear canal, if it was covered, what would happen? So we're gonna take a look at that. First, if you want to quiz yourself, go ahead. You can pause the video. In the PowerPoint I posted, you can move these text boxes around and see what anatomical structures are underneath and check yourself, see if you remember. Okay, so talking about microtia and anotia. Micro is the Latin word for little, and otia is ear, so little ear, microtia. Microtia is just a very small pinna. The ear does not fully develop during the first trimester of pregnancy. So a microtia ear is often smaller in size. It can have a peanut shape like this image right down here. It can only have a small nub or lobe present, or it can be completely absent like right here. Now when the earlobe, when the pinna is completely absent, that is called anotia. Microtia can affect one ear, so unilaterally, or both ears, bilaterally, and it occurs in about 1 out of every 6,000 to 12,000 births. So let's look at a few more statistics. It's also 500 babies in the US each year. So in your profession as an audiologist, you are going to see handfuls of babies with anotia, with microtia and anotia. Most common, it's most common among Hispanic, Asian, and Native American cultures. It's seen in boys twice as often as girls. The right ear is affected twice as often as the left ear. And about 10% of babies born with microtia have bilateral microtia. Microtia is often associated with oral atresia or a missing ear canal. And more than 90% of children with microtia and atresia have a conductive hearing loss. So more than 90% of children with microtia and atresia have a conductive hearing loss, and about 10% of babies born with microtia have a bilateral microtia. So it's usually unilateral. And you will see that in a lot of my examples. Let's go ahead and talk about the development, how this happens. We know it happens in the first trimester. We know it happens, baby's born with it. So let's see. Now looking at embryology, you guys already know this. You already knew all along. That is just so exciting. So we remember the pharyngeal arches give rise to the 6 hillocks that form the major anatomic structures of the ear, right? So hillocks 1 to 3 arise from the first arch, and the second arch gives rise to the 4 to 6 hillocks. So during the 7th gestational age week, the auricular hillocks begin to differentiate, enlarge, and eventually fuse. So this morphogenesis determines the final auricular shape, size, and position. So the ears gradually move from their initial position low on the neck down to the final, more cranial position. So you can see that all right here. And this is what our ear looks like. This is what the different hillocks, how they fuse together. So it's important. You've already seen that the spectrum for, or the degree of microtia is there's a great variety. So the American Journal of Genetics attempted to improve reporting on microtia based on this classification. So this is the one I'm going to read from, but it's just important because microtia encompasses a spectrum of congenital anomalies that range in severity from mild partial structural abnormalities to complete absence of the ear. So there has to be a classification system so one audiologist can tell the other audiologist the degree so they have a common understanding. So looking here, it ranges from microtia first degree to anotia, complete absence of the ear. So the first degree is going to be the least severe. It's going to look a lot like, it's going to have a lot of normal ear components. And then if you're looking at the median longitudinal length, it's going to be more than 2 standard deviations below the mean. But if you're looking at the second degree, it's going to be more than 2 standard deviations below the mean. So it's going to be even more various. And the ear is going to look much less like an ear. And I'll show you an example in a minute. And then the third degree is going to be the presence of some auricular structures, but none of these structures conform to recognized ear structures. And then there's anotia, which is the complete absence of the ear. So let's go ahead and look at a few examples and see if you can figure out what degree each letter is. So they're all different. Some of them are the same. You can pause right now and try to figure out what degree or what classification each ear would be. Okay. So A, I'll go ahead and tell y'all. A would be considered anotia. B and C are going to be third degree. D, E, and F, they all have features that look more like an ear than B and C. So these are going to be second degree. Or sorry, these are going to be, yes, second degree. And then G and H are going to be first degree. G is what is called a cup ear. It refers to a variety of ear deformities when the top rim of the ear folds over or is wrinkled or is tight. And then if you're looking at H, that is called that ear is called a cryptotia. And the upper portion of the ear is buried beneath the side of the head. But those nonetheless would both be considered in the first degree. Also, the classification isn't always called degree. Sometimes it's called grade. So it'll be first grade will be the least severe, and second grade and third grade. And then fourth grade would be anotia. So sometimes they vary a little bit. Causes of microtia and anotia. So the causes among most patients are unknown, although some risk factors have been reported, such as gestational exposure to teratogens, maternal illness during pregnancy, maternal diabetes, anemia during pregnancy, maternal race, higher maternal and paternal age, and higher maternal parity, which means higher number of times a mother has given birth. So little is known about the genetic background underlying microtia. It is phenotypically and etiologically heterogeneous, meaning we don't know much about the observational physical and biochemical characteristics of those with microtia. And they're doing a lot of genetic studies on animals where they identify the genes in animals that have microtia physical features, but there's still a lot we don't know about the genetics. So the most common dysmorphic features associated with microtia are the following. You see a lot of cleft palates, cleft lip and palate, and facial asymmetry. And I'm going to talk about these a little bit more when I go into different syndromes. So for syndromes, there are a lot of syndromes associated with microtia. The most common syndrome associated with microtia is called oculoauriculovertebral spectrum. It's the most extensively studied syndrome associated with microtia, and it's a complex heterogeneous disorder involving the first and the second brachial arch derivatives, which is what we just talked about. So this spectrum is broad, with anomalies including facial asymmetry. Here, let me move this. Facial asymmetry, maxillary and/or mandibular hypoplasia, which will affect the facial symmetry, or facial tags or ear malformations like microtia or anotia or oral atresia and hearing loss. And then there's Goldenhar syndrome. Goldenhar syndrome is a condition that affects the development of the eye, the ear, and the spine. So the main sign and symptoms are facial asymmetry, microtia and anotia, non-cancerous benign growths of the eye, and spinal abnormalities. And we know all of these things because of the brachial arches, spine, mandibular. We understand the embryology, so now we see why these syndromes, they all kind of go together somewhat. So if you look here, we see Goldenhar syndrome. Her case isn't quite as severe as hers, maybe, but you can see she has a benign growth on her eye. And then we have hemifacial microsomia or craniofacial microsomia. And that's a term used to describe a spectrum of abnormalities also that primarily affects the development of the skull and the face before birth. So the facial characteristics typically include underdevelopment of the upper or lower jaw and can be unilateral or bilateral. And then if you see some of our other syndromes, we've already talked about Treacher-Collins, but we'll go ahead and look at this one. A little bit more on Treacher-Collins. It's an autosomal dominant disorder that presents phenotypically with hyoplastic facial bones, microtia, cleft palate, hearing abnormalities, micronathia. Mutations in this gene, TCOF1, have been identified as the cause of Treacher-Collins syndrome in up to 78% of patients. So that we know a lot more about the genes that back up the Treacher-Collins syndrome than we do just about microtia and anotia. Then we have Naegger syndrome. It's a rare condition that mainly affects the development of the face and the hands and the arms. This YouTuber, he's really awesome. He is always working with different individuals of all different ages who are differently abled. And this is a girl who has this syndrome. So if you want to watch and see just how she communicates or what her mom shares her experiences, and you can do that. Also, I really highly recommend watching these videos. It's special books by special friends, and you can look it up on YouTube, and you're always learning more about different syndromes and differently abled people. So you can take a look if you want. But now we're going to go ahead and move on to the genes that are identified in these different syndromes. So though many genetic causes for microtia have been identified with the development of animal models that predictably result in either isolated microtia or abnormalities that includes microtia, we still don't understand the abnormal processes well enough to control them. So our hope is future work will focus on treatment strategies for microtia in animal models that can eventually be translated to humans, that we can learn more about what's going on in our genes to cause these different syndromes and to cause microtia and anotia. Now, as for the type of hearing loss and treatment, because microtia is a congenital condition, so you're born with it, your child's malformed ear, when they're born in the hospital, the doctor, it would be very obvious at birth, and therefore they would be able to diagnose the baby immediately upon physical examination. So doctors are recommended to look at the ABRs, the auditory brainstem response evaluations, soon after the child's birth to evaluate the baby's inner ear function on both sides. But it is shown that babies with microtia, or just individuals with microtia, it's usually a conductive hearing loss. And sensory neural hearing loss is present in 10 to 15% of children with microtia. So, and as for surgery, the care and the treatment of a child really depends on the severity of the case. So some children will need a series of operations, while others won't need any treatment at all. The most common type of operation is called autologous auricular construction. Autologous auricular construction. During the operation, surgeons will take cartilage from the child's rib cage and use it to plant a new ear on the affected side of the head. So the process uses the child's own tissue, which is awesome, because this new ear, if it's ever injured, it can heal itself just as a natural ear would. Autologous construction is performed when the child is 6 years or older, because they need to be old enough to have sufficient rib cage to spare. To spare, yeah, get it? Yes. And 6 years is also about the age when the ear on the other side, if applicable, will reach the approximate adult size. So they will line up and the new ear will match it. Autologous construction usually requires 3 different procedures in total, depending on the type and the severity of the child's microtia. So procedures are scheduled 6 months apart to allow time for the child to heal. So the first procedure, the surgeons will remove some cartilage from the rib cage to build a new ear. This is called first stage autologous reconstruction. And then the second procedure, they will refine and reposition the new earlobe. And that's called second stage autologous reconstruction. Then the third procedure, they will lift the new ear for better alignment and perform touch-ups as needed. And that's third stage autologous reconstruction. And then, so that's infancy, possible headband, hearing aid, and then 6 years of age, first stage. 6 months later, second stage. 6 months later, third stage. And then 6 months later, they might do a bone-anchored hearing aid, a BAHA, or a possible atresia repair, and go in and look at the ear canal if that's determined what's best for the child. It is possible that the child also may need an operation on the middle or inner ear. In that case, surgeons will perform the procedure after the final operation is done. Alternatives to this construction and this surgery includes no treatment. You may opt out to have your child have any surgery at all. The child's care team can help with guidance and advice, can definitely help parents with that decision. But I mean, that's 3 surgeries. That's 3 potential surgeries, and also it could be more. So that's a really big decision to make. Also, there's also ear implants. An artificial ear made from synthetic materials can be used instead of the cartilage. The advantages include no chest scar, ear construction as early as 3 years, so 3 years earlier. Disadvantages include a higher complication rate and potential long-term problems compared to the original construction surgery we talked about. And then there's ear prosthesis. So this type of artificial ear, is made up from a synthetic material, and it can be attached to the side of the child's head with a minimally invasive procedure. The disadvantages include the need for daily care. But parents can monitor the hearing loss with regular scheduled hearing tests, audiograms, recommend hearing aids, or they can look at hearing aids. Hospitals, audiologists, ENTs will recommend hearing aids, other ways to maximize the use of remaining hearing. it can be either worn as a headband or implanted into the bone in the event that it's a very serious hearing loss. And often surgery to recreate a missing ear canal called atresia repair and improve hearing. Uh, so some surgeries, will also include atresia repair. Alternatively, you can do a bone anchored hearing aid, a BAHA. Boston Children's Hospital recommends additional language and developmental assessments for your child. Any child that has any hearing loss or has any child needs to be checked for their language and developmental abilities consistently and make sure they're on track. And then especially these parents can use community resources for educational or financial assistance. Yeah, but that is just about it. Overall, treatment really just depends on the severity of the condition. Early intervention for hearing loss is important for maximizing communication disorders, and parental education and support are essential. And hopefully local, regional, and national organizations may be very helpful. And hopefully we'll one day have a patient with this disorder and we'll know more, and we'll be able to apply all of this. Okay, that's it. Y'all have a good day.